We'll go ahead and get started. Thank you all for being here today for a very special briefing. Joint briefing from Public Safety, Transportation, and Environment and the Health and Human Services Subcommittee. Happy to be joined by my colleague and chair of the HHS Subcommittee, Senator Corey McCray, and also joined by some colleagues from the Finance Committee. Thank you, Senator Hayes, for being here as well. To have a briefing on inmate healthcare. And thank you, Madam Secretary, for being here. This is a policy issue, budget issue we've discussed in last year's budget hearing. You and I have had this conversation a few times over the interim, and we understand that we've extended the current contract, and the two subcommittees and the Finance Committee are just interested in learning more about that decision-making process and learning more about what steps are ahead of us as we work together to nail out the FY25 budget and make sure we're meeting all of our policy goals. So with that, Secretary Carolyn Scruggs from the Department of Public Safety and Correctional Services is here, and I'm sure she has a team that would like to join. Please, Madam Secretary.
Oh, good morning, Chair Alfred, Chair McCray, members of both the Senate Public Safety, Transportation, and Environment Subcommittee and the Senate Health and Human Services Committee. For the record, my name is Carolyn J. Scruggs, and I'm the Secretary of the Maryland Department of Public Safety and Correctional Services. With me today are Deputy Secretary of Administration, Joe Sadal, Assistant Secretary for Programs, Treatment, and Reentry Services, Mr. Renard Brooks, our Director of Clinical Services, Dr. Jerkins, and our Director for Substance Abuse, Mr. Michael Richards. Thank you for providing me the opportunity to share information about the importance of health care for our incarcerated individuals. The department operates the Division of Corrections and the Division of Pretrial Detention and Services, among other division boards and commissions. And I am going to stop to acknowledge Senator Hettleman, my senator. Welcome, and understand congratulations is in order for Grandma. So thank you there. The DOC operates 13 state correctional facility housing offenders sentenced to periods of incarcerations of 18 months or longer. The Division of Pretrial Detention and Services within the department oversees the Baltimore Pretrial Complex, which houses pretrial detainees and incarcerated individuals sentences to periods of 18 months or less. Both the DOC and DPDS are responsible for 24/7 supervision of individuals who have been ordered to periods of confinement. Supervision entails providing housing, meals, and medical services, in addition to preparing individuals for reentry into their communities. In the FY23, the DOC's average daily population was 15,494 sentenced individuals, while DPDS's average daily population was 2,179 individuals. One of the department's top priorities is to provide incarcerated individuals with the correctional facilities with programs, treatment, and reentry services. The department utilizes a multidisciplinary vendor approach composed of contractual and full-time licensed clinical professionals to treat the incarcerated population. This includes full-time and contractual staffing for medical treatment services and full-time and contractual staffing for mental health services. The department's Office of Clinical Services oversees a healthcare delivery system that provides comprehensive primary, secondary, specialty healthcare, and hospitalization services. The healthcare system provides medical, psychiatric, dental, and pharmacy services through competitively bid contractual relationships with private healthcare providers and having expertise in their respective healthcare disciplines. Upon intake into the Division of Correction, each individual undergoes a number of assessments, including a medical exam, a mental health evaluation, a substance use disorder evaluation, a security classification, and a risk needs assessment. As you know, House Bill 116 of 2019 required the development of a comprehensive medication assisted treatment pilot program at the pretrial complex in Baltimore City. The goals of the MET pilot program encompass an individual's experience while detained, starting with screening and assessment upon entry into the detention facility, increasing medication options, behavioral health treatment, and peer recovery support while detained, and offering re-entry services as they prepare to re-enter the community. Each individual, upon entering Baltimore Central Booking and Intake Center, receives an evidence-based screening and assessment to determine if there is a clinical diagnosis and an opioid use disorder. If the assessment indicates an opioid use disorder, a healthcare practitioner conducts an evaluation, and if deemed appropriate for treatment, the practitioner provides information regarding the medication treatment options available. Even prior to the passage of House Bill 116, DPDS has been operating methadone continuation program at BC-BIC and the Metropolitan Transition Center for several years. This program offers continuous care for individuals who are on verified methadone or Suboxone-based product prior to being detained at DPDS facilities. The department added the Sublocade and Suboxone and nalextrin to methadone as medication options used to treat opioid use disorder. The services are being offered continuously at BC-BIC and MTC. The department has also met the requirement for staffing 10 medical providers who are capable of prescribing MAT by cross-training some of its primary care providers. To add support the MAT services, the department hired a peer recovery specialist in December of 2023 and has a second candidate currently in the hiring process. The role of these two peer recovery specialists is to aid in the intake and screening process, aid in supplementing the counseling services, and to aid in preparation for re-entry and connecting clients to community resources. The DPDS applied for and received an Office of Overdose Response grant for FY 23-24 that allows for the expansion of MAT treatment services to more patients. This has added a limited offering of injectable Sublocade and increased the re-entry services offered to returning citizens. The department applied for and received another Office of Overdose Response grant for FY 24 to continue the expansion of Sublocade. The grant builds off of the foundation of the FY 23-24 grant. The department and DPSCS are currently working with our contract medical provider to implement these services for both grants. In September 2023, the department began expanding MAT treatments to DOC to allow transfer of the sentenced individuals from local detention centers who were receiving MAT services to remain while they were incarcerated in the Division of Corrections. In addition, the department's clinical services joins bi-weekly meetings with the local wardens and now have weekly meetings among case management, the medical vendor, and the DOC wardens slated around MAT. Moving on to the healthcare contracts. The department has been operating 2 service contracts, one for medical services through YesCare, and one for mental health services through Centurion. The contracts were initially scheduled to expire at the end of 2023, but were extended to March 31st, 2024 to allow for the procurement of a new medical and mental health service contract to improve and conclude these contracts. These contracts were extended at no cost. Time-only extensions. via the delegated authority granted to the department under BPW Advisory 1995-1. Separate medical and mental health contracts are more cumbersome and provide natural barriers to the collaboration between somatic medical and mental health clinicians, potentially impacting the care provided. Contract management across all facilities for each contract can also lead to communication challenges. We determined these challenges could be eliminated with a contract awarded to a single vendor for DOC facilities that includes the two distinct specialties, and another contract for DPDS facilities that also includes two distinct specialties. Care can then be provided holistically to an individual for the length of time they are housed. The care can then be coordinated and streamlined should the incarcerated individual be transferred. A single file will include both the medical and mental health information for that individual. This is exactly what we did, as we believe that by separating the contracts for the different populations, the coordination will improve tremendously. Another benefit of the new contract will provide additional resources to support all mandates of House Bill 116. This will allow the expansion of MAT and counseling services to all of our pretrial facilities. The pretrial solicitation went public on October 10th, 2023, and closed on December 18th, 2023, for a total of 56 days. The solicitation for the Division of Corrections went public November 14th, 2023, and is currently set to close on January 19th, 2024, for a total of 66 days. Procurements of this type are required by law to be solicited publicly for at least 21 days. Due to the complexity of these procurements, they have been publicly available for a significantly greater number of days. I would also like to point out that in addition, we have a number of substance use disorder treatment services contracts to provide substance use disorder screening, assessment, reentry support, therapeutic counseling services to detainees and incarcerated population in support of the implementation of MAT. The department has submitted several JCR reports on these issues for 2023. That concludes our testimony, and we are happy to answer any questions.
Madam Secretary, thank you. I just wanted to make sure that I was clear. In reference to House Bill 116, what year were you referencing?
That was that 2019, Mike?
Yeah.
2019.
Okay.
Yeah.
Thank you.
I have a number of questions, Madam Secretary, but I'm going to open it up to the subcommittee for questions first. Okay, I will kick us off then. Madam Secretary, you mentioned the extension of the current contract with YesCare for an additional 3 months.
3 months.
I thought I heard you say that will come at no extra cost.
That is correct.
Can you explain that a little more,
I'm
please?
gonna have my deputy explain.
Thank you.
You want to tell y'all?
So the contracts, they're no cost, time only extensions by definition, because the contracts are awarded as not to exceed value contracts, basically creating an upset limit. So when the Board of Public Works approves one of these contracts, they grant a certain amount of authority to spend under the contract. And that, again, is the upset limit. In the scenario for both of these contracts, the upset limit had not been increased or had not been met yet. So the continuation of the extension allows for that NTE value to be met. So there's no additional cost from what was originally budgeted and approved by the contract.
Thank you. I will keep going then. Okay, so Madam Secretary, you mentioned the time period you left the RFPs open for both potential new contracts. I know you can't share too much detail on the responses you've received, but are you satisfied with the responses to the RFPs that you've received? Do you feel like you're going to be able to make a new contract in the time period you set forth for yourself without having to go back to bid?
So we will make a new contract. We had a number of questions, which Joe can kind of speak to just briefly, but like you said, we can't go into detail. But we do have vendors that we are reviewing right now, and so far we're satisfied. We haven't come up with any hiccups. So.
Yeah, I think that's it. I mean, like you said before, we can't talk a lot about it. We are currently with the pretrial ongoing evaluations at this moment. The goal is still to have awards prior to the expiration of the additional contracts. Whether or not that is possible, there are any number of kind of hurdles that could pop up. One of the most prevalent is, I'm sure you're all aware, if a protest comes, then that's something that has to be dealt with. And it's something that's always a possibility within procurement. The hope, though, is that we'll conclude the evaluations, make the recommendation award, and be able to get it to BPW prior to the expiration of the existing contracts.
Hopefully also with enough time to implement the new contract. I'm sure you're baking that into your time frame as well.
Yeah, that will
Okay.
include, the idea is to include any level of transition period as
Okay.
well.
Thank you. Senator Salling.
Thank you, Madam Chair. Just a quick question. The previous contract that you had with the previous contractor, and ongoing has there been any problems with the previous contractors that were there? And if there were, I mean, can you there's some background music. Thank you.
It is. Say it about your question.
But we just like to know maybe if there was any problems. If there's not, that's fine. But if there is, if they were ongoing, if there's something that there need to be a conversation that we need to talk about. But other than that, if everything was going well with that contractor, it would be good to know. Thank you.
So are we referring to medical or mental health or both, sir?
Yes, sir.
Both. Let's start with Centurion, which is our mental health contractor. They have been on par with everything. We've not had any problems or any challenges or hiccups with them. With Yes Care, I was with them through the COVID period. So during the COVID period, we had some challenges with them understanding their roles and things of that nature, but we were easy to resolve those issues. They stepped up to the plate and did what they had to do. We also worked very closely with Yes Care, the current vendor, to make sure that staffing levels were where they needed to be because of the competitive nature of what was going on with COVID and the inability of just medical all around not being able to hire. So I would say for the most part, they've worked very well with us.
Okay. Thank you very much. Thank you, Madam Chair.
Thank you, Madam Chair. I know this isn't only your purview, but I'm also very interested if you can shed some light on the activity and collaboration coordination between you and the Department of Health on patients who need psychiatric care, both those behind bars getting the care and those making the transition between state psychiatric institutions and others and DPS.
Thank you for that question. I am in constant conversation with Secretary Aurora Scott about that because we are a correctional facility. We are not built to take care of those types of patients. We do right now have approximately 29 patients that have been committed to the Maryland Department of Health that are housed within our facility because we cannot force medicate. Our doctors and our nurses are managing them as best they can until that transfer and bed availability becomes available through Department of Health. On an average, they're taking about 1 a week from us, but we're also receiving maybe 2 or 3 new commitments every week. So we are tracking that and we are working very closely with health to try to resolve that, but we do have them here.
And that's not to speak of the local pretrial institutions that may be housing people because they are not other services for them.
Correct. That is not the local detention center. These are just the ones that are housed in Baltimore City at our mental health unit there. And then we have a couple that we still have housed at some of the DOC facilities. But the last report on Monday, there were 29.
Okay. Okay. Follow up. Thank you. Can you tell me a little bit about how, because this is obviously a perpetual issue, and kind of is there a sense of urgency between you and the Department of Health on working through these matters? And do you have a bi-weekly meeting to figure out what happens? Can you just tell us a little bit about that collaboration coordination?
There is absolutely a sense of urgency because we don't want to see those individuals decompensate. We want them to receive the care that they need. So there is a weekly review done by our clinicians. That's how I receive that report every Monday to know what's going on. And that's how I then incorporated ensuring that Secretary Rara Scott gets a copy of that report. So she's CC'd on it. And if we have individuals that what we call are extremely high, then we make reference to that because we said this person is detrimental. Can we make a difference and get him or her moved? So there is constant collaboration there.
Thank you.
Thank you, Madam Chair. Madam Secretary, I'm gonna tell you from the beginning, I'm less familiar about the structure of public safety. But I'm curious, is there a medical director that usually coordinate medical services and help inform the scope of work in preparing the RFP when it's issued? What does that structure look like?
So for this RFP, actually, Dr. Jerkins is our Director of Clinical Services. He is the doctor for our department. He was not here at the inception of this, but we did confer with Maryland Department of Health. And I want to give thanks to, again, Secretary Rara Scott, who took the time to read all 500 pages of that RFP and give me feedback and insert information that needed to be in there. So we worked very closely with them and I can let the doctor speak, but he came in and he did also his preliminary review and then we got it out. So Dr.
Yes, so Dr. Oscar Jerkins, and I do have a number of years of correctional health care experience as well as in the private sector prior to that. But I just came on board within the last 11 months and got quickly up to speed with the scope of the needs within the department with the medical vendor, mental health vendor being under separate companies, as well as the DOC versus pretrial scenario, because those are two that there's some complexity there since this system has both the DOC and pretrial.
All right. And I'm sorry, Madam Chair. And so like as I think you didn't refer to him as the medical director. What is your role? I'm sorry, Dr. Jerkins.
So as Chief Medical Director, I oversee our relationships with those medical vendors, both really the medical, mental health, pharmacy, and dental vendors that are involved.
Got you. So there's no direct service to the individuals.
Correct.
You're overseeing
Oversight.
contracts by a private vendor that handle all of those services.
Correct.
And then I believe the secretary had alluded to the pharmaceutical services. That's a separate contract.
Correct.
That's
RX.
independent of the both medical and the behavioral health services
Yes,
that
sir.
you guys are providing.
That
Okay.
is.
Thank you.
I do want to make it clear, though, that Dr. Jerkins has a team that works for him. So they are state employees that help to monitor those contracts, audit. There's an audit function that his team does to ensure that they are in compliance with whatever the contract says. He also has nurses that work for him that are out at each one of our facilities that are actually on site, ensuring that they are monitoring and that those contracts are being held accountable.
There we go. It takes a while. But delay. Interesting. So I think the other question, so like things like CRISP and like the electronic medical records and things like that, is that handled also by the private vendor, or is that something that's handled by the state employees in this case?
So of course, the medical vendors interact with the electronic health record, although it is a record that was chosen by the state and is administered by information technology resources within the state.
And how, I guess, how is health insurance applied? Who builds and how is the insurance for the medical care provided?
So with the care that's provided, primary care essentially, or primarily primary care provided within the walls, if you will, within the correctional facilities, is of course just by virtue of the
Medicaid.
contract that we have with those medical vendors. When when patients are sent out, it is typically Medicaid services, which they qualify for. Hospitalization services.
Yeah, but they have to be inpatient hospitalization in order for us to be able to apply for the Medicaid services.
Right. But as long as they are being seen by your provider, it's already assumed in the contract. There's no
contract.
separate billing for that. Right. It's only when they have to have services outside the walls and working with maybe some of our community-based health centers or clinics or hospitals.
Correct.
Correct.
Gotcha. Thank you.
Thank you, Senator Hayes. We did, for the record, invite MDH to be here because, Madam Secretary, you've been very clear that they are being very helpful to you with the RFP. Are they also going to be helpful to you in evaluating the responses that you're receiving and help you pick the best contract?
We'd prefer not to discuss the evaluation committee, given that they are ongoing evaluations. If that's all right.
I will just note, I hope MDH continues to be helpful as you evaluate. Senator Hayes leads me to my next question, which is services outside of the system. So our hospitals who are a partner to you in severe cases. We've received feedback over the last year that there's been a delay in them receiving reimbursements. Can you speak to that? And is that also, are they in any way, I know you don't want to discuss the evaluation committee, but again, I would hope that since they are partners in this care, that they are taken into account when you are selecting the next contract.
I'm sorry, could you repeat that last part?
I rephrase it in a question. To what extent are our hospitals who are partners in care, again, for the most severe cases of folks who need services outside of the system, to what extent are they involved in your selection of the next contract?
The actual hospital systems themselves?
The hospitals that you use for extra care?
I would say they're not. They're not part of the DPSCS state executive branch process. So they wouldn't be engaged in any sort of evaluation, if that's what you're referring to, like an evaluation of the selection of a vendor. That's a state purview.
I understand. My question is, since they are a partner in care to the medical director, they are a partner in care, some of the hospitals, when you have severe cases, to what extent are you considering timely reimbursement for that care in the next contract?
So what I can say is that anytime, if during an existing contract or anytime you're making a recommendation for award for a procurement, right? There's kind of two main sort of spheres that you have to make that evaluation, right? And it's responsibility and responsiveness. And not to bore everyone with, procurement details, but ultimately, past payment issues, something like that could be considered something within the responsibility determination. I hope that answers your question.
Yes, and I think you understand just how much we are considering that aspect of this care as well, and just counsel that you do too. I believe Senator Jackson and then Senator Rose Pope.
Thank you, Madam Chair. Thank you for the presentation, and part of my question was answered from an evaluation standpoint and consideration. And obviously, we don't want to get into the particulars of your selection process. However, when these two committees and others have had conversations regarding the health and care and welfare of inmates who are our citizens of our state primarily, that is a concern. Madam Secretary, so the transition, we've extended until the end of March, roughly. The transition, when you bring in a new provider, could you speak to that, or could your team speak to that transition and how are you assured, or where the assurances are that the ample care is being taken? in that process?
So I'll tell you, given my experience, I've been through several transitions over the years. Typically what happens is when that new provider comes in, they're going to reevaluate all of the medical staff that are currently there. Nothing will stop, but they do have the option to re-interview, reevaluate to determine whether or not the medical staff that are currently providing services are equipped to meet the contract or meet the needs of that new provider. If they're not, they will interview and replace them. If they are, they will continue to be employed under that new contractor. So they have that option. And it's been a smooth transition in what I've experienced over the years. So that medical contractor will then come in and make sure that they are able to meet every standard that we have placed in that contract. They will continue to have conversations with my director of clinical services, as well as the assistant secretary for treatment services. And we have an audit unit, a medical audit unit that will ensure that we are actually looking at and assessing those standards that were placed in the contract on a monthly basis to make sure that they're meeting time intervals for, say, medical exams that are required annually, or time interval for intake exams that are being done at Baltimore Central Booking, and then they will be held accountable if they're not. So that transition, it should be pretty smooth for the most part. I don't know, Dr. Jerkins, or anything else you think?
I agree completely. Obviously, there would be extensive interaction with the new vendors. I would likely say on a daily basis in the transition period to ensure that smooth transition. And again, the providers, the clinicians that are already employed within the system, and in many cases have been working with the patients for a number of years, remain in place while those kinds of evaluations occur.
And Madam, if I might, Madam Chair, so the transition period, so you've been through, Madam Secretary, at least 7 of these. How typically the time allotted or the time that you've seen for that transition?
It's usually about a month or so, because they actually go through, what I've seen is they go through the credentialing to make sure that credentials are still straight. And if they're not, then they're letting people go and getting other people on board. But the onboarding process, we make sure that we help to expedite that through any background checks or anything they need to bring anybody else new on. But we are really big on vetting who we have come in to support healthcare for our incarcerated individuals. So that credentialing and onboarding is going to be big. And it's, like I said, within a month turnaround, we should see everything just kind of stabilize.
I appreciate that, Madam Chair, if I might. So from an evaluation standpoint, if I were a provider in the with the current contractor, and for some reason I was not kept with the incoming contractor in either realm, is there a process by which the department has in place to from an exit interview, survey interview, some type of evaluation of who that individual was, why that individual, and of course the contractor comes in and wants to build their team, but I think there's oftentimes valuable information when someone leaves a position that they've been in. Does the department have anything set up in that regard?
We do not have an exit interview because they are employees of the vendor, not of the state. So any exit interviews would be done with the vendor.
So I guess my concern here is they have been providing a service to you. I understand that contractor, may, or we should hope that they have some sort of exit interview so they can further find out any challenges or any, hopefully a bunch of positive interactions or experiences. So I would love to speak to you further about that and how that could help the department in gathering information, necessary information going forward. So,
Mr. Brooks, did you add something? Mike,
the question that you asked about the exit interview, I wanted to expound upon, we work with them closely day in and day out. So if there's any issues with that provider, for example, between the doctor sitting here, the nurses that are stationed at the facilities, the monthly meetings that we have with medical that goes over a whole array of what's going on with the patients and the contract. I don't think we might find out any great additional information that we already know because of the close interaction. We have to stay on top of it to make sure they're doing what they're supposed to do and monitor what there is. And when it comes to transition, I guess I can speak personally because before I retired with 36 years as assistant commissioner for the department, I worked for Wexford Health Services and came back to the jail and worked. So I've seen both sides of the equation. And traditionally, they keep the same staff because they have to. And when I say they have to, I mean, if there's not some egregious reason why they shouldn't keep them, they have to keep the ball rolling. So they already know the patients, they already know the system, and everybody has the choice whether they want to stay or they want to go. And still using myself as an example, when that Wexford contract ended and it transitioned to this one, I chose that I didn't want to stay with that new company. So I went and seeked up opportunities. And I've been back in this role for 6 months to support the secretary as the assistant secretary for programs, treatment, and reentry.
I appreciate that. However, I believe there's always opportunities to learn more and to do things better. And I come from a public safety background as well, understanding exactly where you come from. I think there's a reason we're here today, ladies and gentlemen. So we're just trying to get to the point of having a discussion. I've asked the secretary to maybe sit down and have a conversation to how we can maybe further understand the transitional opportunities that come your way by contractual means and in other means. So love to have that opportunity.
We'll definitely do that, sir.
All right, thank you. Thank you, Madam Chair.
Yeah, this is an uninformed question and it may have already been answered while I was out of the room, so I apologize for multiple reasons. To what extent is the cost of corrections healthcare covered by Medicaid or not?
Regarding Medicaid coverage, that's typically the outside of the system. In other words, hospitalization services.
And that's because, and it's limited to that because
in most jurisdictions, including states, when someone is incarcerated, they're the responsibility of the state in terms of the cost of their care. And the insurance programs, whether they're private insurance or the public health insurance, are not involved in the primary aspects of that care. Unless they go outside to the hospital, then Medicaid covers.
And is that because of federal rules or state rules?
My understanding would be both, although I'm no expert in those matters.
Madam Chair, if that's something we get a little more information on from somebody, not right now, I'd appreciate it. Thank you.
Thank you, Madam Chair. I don't know if you can answer this question, but can you tell us how many companies have bid on the contract? Are you allowed to tell us that?
When you say how many people are on the contract?
No. How many companies are bidding on the contract?
I would prefer not to answer that at this juncture, given that's an open procurement. I can say that we've received multiple proposals.
Multiple proposals. Okay, thank you.
Thank you. Any further questions? Okay. Madam Secretary, thank you for and your team for being here, answering our questions. I think you've seen some themes, heard some themes today about what's of interest to the budget committees and the finance committee. I would suggest taking those questions and themes to heart as you are evaluating. Of course, it's your responsibility to evaluate the procurement system, but I think you heard where our hearts and minds are today. And the good news is that we're going to be seeing quite a bit of each other over the next few months. We have our DPSCS overview on January 25th. So I imagine we're going to continue this conversation. I look forward to that. But while I have you, could you just share your ideal timeline moving forward on both contracts?
So our plan is that by the end of March, we will have an award for both of the contracts. Again, as we talked, it usually takes about a month for that transition period. And we'll get that transition period going right away and be up and running, but there will be no break in the continuity of care for those incarcerated men and women that we have.
Thank you. Seeing no further questions, Mr. Chair. Okay, we are adjourned for the day, and I believe the full committee's meeting at 1 downstairs. Thank you, Madam Chair, Madam Secretary.